Hello, everyone, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course, we are here with Chief Medical Officer of the Centeno Schultz Clinic, Dr. Chris Centeno. Happy Monday to you.
Happy Monday, Jason.
Well, welcome, everyone. We appreciate when you join us for these shows week after week after week. Today, we have another exciting topic, especially if you're in the category of wanting to learn more about cranial cervical instability. Our topic for today is what is medullary syndrome and how does it relate to CCI, again, cranial cervical instability. Dr. Centeno, this is a topic we tend to go very deep into because there are a lot of people who suffer from this on a pretty chronic basis and not a lot of places to get not only information, but more importantly, accurate information. This is a procedure and a program you have been an expert at for quite a while, so let's unpack what we need to know about cervical medullary syndrome.
Yeah, so cervical medullary syndrome is a topic that overlaps quite a bit with CCI or craniocervical instability. So basically the dent or part of the C2 bone can come backwards into the upper spinal cord and into the brainstem, otherwise known as the medulla. So what can happen is you get irritation of the upper cervical spinal cord and brainstem that can lead to symptoms like headaches or numbness and tingling or weakness in the arms and hand when the head is in certain positions. Usually this is due to loose ligaments in the upper neck. The alar and transverse ligaments that basically hold the head on get loose. Sometimes that can be due to the patient having loose ligaments to begin with, like EDS, and sometimes that's due to damage of the ligaments themselves due to trauma.
Let's get into more details. How do most people find out that they have this diagnosis? How do doctors diagnose it? And how is it differential from other possible potential likely diagnoses that might be similar?
Yeah, so basically patients present with headaches and imbalance and numbness and tingling and weakness. They go to their doctor. The big problem is that it really takes a specialist to diagnose this. So for example, I saw a patient last week who had been on this quest to figure out what was wrong with him for 2 years. No one ever noticed the cervical medullary syndrome that was obvious on his images, and he asked the same question: how is it possible that nobody knew that this was there? I showed him it was there, and the answer is, WNL in medicine means within normal limits. That's what we write on our reports, but it also means we never looked. So basically, there was a whole bunch of specialists he saw that really didn't understand craniocervical instability, really didn't understand the upper neck. They were looking lower than that for the common things. They kept sort of rubber stamping normal MRI, normal MRI, normal MRI. So it takes sometimes getting to see a specialist that understands this area to get a diagnosis. Other times getting a flexion extension MRI can be very, very helpful because that can show the actual impingement, especially as the person flexes forward.
This reminds me of, I know back in chiropractic school, there was always sort of the saying that people tended to have the conditions that we were studying at the time. So it's what you, as you say, what you look for or don't look for. And another, common, I'll say, maybe unfortunate reality is that doctors oftentimes look for those things they can fix or can charge to fix and tend to ignore those problems that they don't have solutions for. Is there a sort of traditional medical solution to this that is recommended? Or for the most part, is it not commonly diagnosed because it's not commonly diagnosed?
Yeah, so a lot of these patients end up going to physical therapy. They tend to get worse in active type rehabilitation or physical therapy, just like CCI patients do. In addition to that, some of these patients will see an upper cervical chiropractor and get some relief because they can reduce the rotation of C1 on C2, which happens with instability. And then really after that, the only type of treatment that's often recommended is an upper cervical fusion. More recently, this last 5 or 6 years, we've actually offered patients the ability to tighten those ligaments that hold the head on, alar and transverse, and that seems to have a good track record in helping many of these people. Many of these patients will also get offered traditional posterior prolotherapy. That usually isn't all that helpful because it's not addressing those ligaments that hold the head on. So that's kind of what's out there as far as treatment is concerned right now.
It is again, another example of why you've got to advocate for yourself. That just going sort of the traditional medical route, being passive through the system, will likely lead to a diagnosis that oftentimes leads to drugs, steroids, and surgeries. And if that's not what you're looking for, because according to the research, those tend not to give you the most favorable outcomes, then you've got to really invest the time and energy to look for other solutions, learn about things on your own. This is yet another one of those topics. Doc, is there anything I should be asking you about the topic or anything else you want to mention before we get to some of the questions that are coming in?
I think the big thing is just to realize that there is this overlap between CCI and CMS, cervical medullary syndrome. You really need the ligaments to be loose for this kind of thing to happen. It can also get worse by a pannus and the back of the dens or C2, and that there's a blog tomorrow on the regenix.com site where I tend to blog, and we'll probably repeat that with one on the Centeno Schultz site at some point on cervical medullary syndrome if you're interested.
Excellent, excellent. That is, if you're watching, if you've got questions about yourself, your condition, if you'd like to ask a question directly to the world's foremost expert on regenerative medicine, Dr. Chris Centeno, now is your time to ask. I'm going to start, here we go, start asking away. This was submitted in advance by Roberta Shirley, and her question is, can you have both CCI and cervical medullary syndrome?
Yeah, in fact, I would say that right now, of the many CCI patients we see at Centeno Schultz, that probably 20 to 25% of them also have a cervical medullary syndrome. So it's very, very common in CCI patients.
Good to know. Is it important for people to be diagnosed with it, or when they come in for their PICL procedures or other procedures, you're going to handle and look for these loose ligaments anyway? How important is it for somebody to sort of get that as a specific diagnosis, and what impact would that or does it have on your treatment or recommendations for care?
Yeah, so we will make this diagnosis if it's present, and we are still trying to understand if it has any impact on care. But just realize that it may change some of the things we do. So for example, in the PICL procedure, if someone, for instance, has a large pannus, and that's a swollen bursa behind that C2, which can make all of this worse, sometimes when we try to go below the dens to inject those ligaments, or sorry, not below the dens, but below the atlas to inject those ligaments, that can lead to what we're injecting going into that enlarged bursa and not getting into the ligaments, in which case we would have to switch immediately to an above the atlas type approach to make sure that we get the ligaments we want to. So this diagnosis itself could certainly change how we approach your specific problem with the PICL procedure. And since we're using X-ray guidance with contrast to see exactly where the stuff we inject will go, the doctor will get that instant feedback and be able to make changes to your procedure to try to avoid just injecting into the bursa or the pannus, and to try to target the specific ligaments that are loose.
That is one of the most important parts when you're looking for a doctor, looking for treatment, looking for care, is exactly what Dr. Centeno is talking about right now, and that is, having experts know what they're looking for, and the use of image guidance is one of the most important parts of what makes the Regenexx network and their training different than what you'll find at most medical professionals, orthopedists, and so on. That is very much part of what I refer to as the Regenexx difference. I don't see that or hear about that much in the traditional system. Do you, Doc? Is this somewhat unique to your practice and what you teach those doctors on the Regenexx network?
I'm not quite sure what you're asking there.
I'm asking about your use of image guidance and your diagnosis and knowing to look for whether it's pannus or whether to go below or above. Most other doctors don't even have this conversation. They're not even looking for these things. They're not trained to look for these types of incidents, artifacts, or causes for that matter. And that's really one of the unique parts about anybody on the Regenexx network, but specifically you at the Centeno Schultz Clinic.
Yeah, so realize that for this particular topic, craniocervical instability, the only site that we have that has expertise is Centeno Schultz in Colorado, or the Regenexx HQ site. We do have a network around the country who can handle many, many other problems. And those doctors are specifically selected based on their skill set, and then get quite a bit of additional training to be able to do this type of work. And then from there, those doctors use imaging guidance, whether that be ultrasound, fluoroscopy, or both. And that's the advantage of using imaging guidance. Just like I said, in this particular case, if we are inadvertently injecting into this enlarged pannus or this bursa because it's just so large that we really can't get out of it, we know that, and we know that's going to reduce the likelihood of this working, because the bone marrow concentrate in that case is all going into the pannus and not going into the loose ligaments where it needs to go. And that's the advantage of imaging guidance just in general, is you can see where the stuff is going and make corrections in your technique to try to improve the outcome for the patient, which is not something you can do if you're doing this blind.
That was exactly what I was asking, so thank you very much. All right. Maria Malisova asks the question, is it possible that a pathological CXA and Grabb-Oakes can stem from a subluxation of C1, C2, or is it always clearly ligamentous instability?
Well, we just have to start defining those terms. So from a neurosurgical standpoint, subluxation means that a joint is visibly displaced on imaging. So if we're talking about a C1, C2 joint, it's out like that, meaning that that's a neurosurgical emergency that requires someone to have immediate surgery to prevent their death or otherwise their dismemberment, if you will, of the spinal cord in that case. Now, that's the neurosurgical definition of subluxation. Then you get into the manual medicine definition of subluxation, or chiropractic definition, and that's where a joint is not aligned properly and it needs to be put back into place. So if we're talking about the second one, then realize that a CXA, and let's sort of review that for a second for all the viewers, is called a clivoaxial angle, and that means basically that the head or the skull is rotated forward relative to the upper cervical spine. Now that's usually due to loose ligaments, because there's really no other way to get there other than loose ligaments, or on the rare occasion that someone is born that way, that's called congenital. So at the end of the day, though, just realize that it's usually loose ligaments that cause the increased CXA. Now, Grabb-Oakes is a measurement of how far that dens is going back towards the spinal cord, which is what we're talking about here with a cervical medullary syndrome. And that's due to looseness in the alar and transverse ligaments specifically, and that causes an increased Grabb-Oakes, especially when the person flexes down. So just wanted to make sure that you understand that when we use that term subluxation medically, it means a very different thing than when it's used more from the manual medicine perspective.
And you did mention earlier that in some, I guess, maybe more mild cases, that some symptoms can and are relieved through upper cervical care. So there may be a continuum there early on that it may be that adjustments are able to help them relieve their symptoms from this. So depending again, Maria, on your definition, I guess that hopefully answers your question. If you still have a follow-up, please ask it below. We've got some time on our show, but thank you for asking. Okay, this is from Shannon Alita, and she's got a couple statements here. I'm not sure there's a question, but I'll share it with you if you have any comments. She says, I am wearing magnets right now for pain relief and care for myself. She then goes on to say, Motrin and Benadryl are the only drugs I take as needed. Again, I don't have a question with that. Those are just two comments. Anything you want to comment on magnets, drugs, Motrin, and maybe the difference between sort of symptomatic relief and, really looking at imaging to find out what structurally and functionally is going on, regardless of symptoms, and the difference between those two may be a place to go with that.
Yeah, I'm not an expert in electromagnetic medicine or whether that stuff works or doesn't work, so I've probably got no comments there. As far as using drugs like Motrin, just realize they're a two-edged sword. On the one hand, they can be very effective at reducing inflammation and pain. On the other hand, they do increase your cardiac sudden death risk. So Motrin about triples that risk over what it would normally be. Same thing for the risk for a fatal stroke. Both of those related to heart arrhythmias caused by non-steroidal anti-inflammatory drugs like Motrin. So, so while taking Motrin is certainly safer than taking OxyContin, it does have its risks, so just be aware of that.
There you go. Thank you for that. And Shannon, thanks for sharing. Thanks for watching. Lloyd Studios William, hopefully I said that right. That's what he's got here. My wife fell and hit her face on a cement lamppost base. I'm sorry to hear that. It gave her a TBI and exasperated a Chiari-1 malformation. It also tweeted her C2. Can you help? Just reading it as it says. Your thoughts on that, Doc?
Yeah, so I probably need to see the images to see how significant the Chiari is. So just so everyone understands, a Chiari malformation is when the brainstem hangs low in the skull. And usually, if that kind of trauma made that worse, then the problem there would be that the ligaments that hold the head on got damaged, and that's what's making the Chiari malformation worse. So again, the focus of these treatments that we're talking about here today, one being the PICL procedure, where we inject the ligaments that hold the head on, would be to regain that stability, so to make it like it was before her head hit the base of the lamppost. Yes, this kind of thing can help that kind of problem, but I would need to look at the images to get a better sense of what's going on with the Chiari.
I'll follow up on his behalf and perhaps others that may be listening and watching. The process, if somebody has had an injury, if somebody's experiencing these symptoms, if somebody's curious to learn more whether they may have this medullary syndrome or CCI, is that they would reach out to the Centeno Schultz Clinic. They can schedule either a telehealth visit if they're not local. They could come to the office if you are local. And do you want to maybe just briefly explain kind of what the process is, examination, imaging, etc., for people who are interested in taking the next step and getting some help?
Yeah, so the best way to deal with this is, for instance, you're probably not in Colorado where the Centeno Schultz Clinic is located, just based on the odds, if you're watching this. So as a result, the best thing to do is a telemedicine initial evaluation. The good thing about the pandemic, if there was anything good at all, was that physicians are now licensed to practice in all 50 states, and at least right now that continues. So we can actually now do an insurance-covered evaluation with you over telemedicine. We can order films and things like that. If we need additional information, review your records, come up with a diagnosis, etc. And our goal there is to try to see if the types of procedures we offer, including that PICL procedure, is right for you. and if you're a good fit. And then obviously we can have you come out here and then make the decision about what it is you need. But just realize that we can do this over telemedicine now, and that makes it much, much easier for someone who's sitting, across the country with this problem, trying to figure out how can I get some help. You don't have to step on a plane to get to start the process.
Excellent information. Thank you. He proceeds to follow up with, thank you. I will send you images. And he's referring to MRIs and such. So Lloyd, thank you for watching, and we look forward to you reaching out and getting some help. Justin Eddy says, thank you for the info. I just want to clarify that cervical medullary syndrome is a condition primarily related to C2. Do measurements like CXA and Grabb-Oakes reflect cervical medullary syndrome, or are they only showing instability at C1?
Yeah, so two different answers, but they're similar. So what that means is instability measurements. So we have two types of instability measurements. Ones that are static, like a Grabb-Oakes measurement or a CXA. And now those can be done also on movement-based MRIs, for example. And then we've got dynamic images where the person's moving around, something like a DMX, and then we're taking measurements on the moving bones, if you will. So now we're talking about static images. On the static measurements that we do, Grabb-Oakes generally reflects how far back that C2 goes. Now, what it doesn't really measure is how close it gets to the spinal cord or the brainstem. So it's not directly measuring the issue of cervical medullary syndrome. Same thing with clivo-axial angle. That's going to be, again, more how far the skull is relative to C2. And realize that both of those tend to be relative to C2 type measurements. So how far back C2 is relative to the atlas for a Grabb-Oakes, how far forward the skull is relative to C2 for a CXA.
All right. Thank you for asking, Justin. That was also, Matt, these details matter, both the millimeters and the focus of what it is that we are looking for and talking about. We've got a follow-up from Shannon Alita, who says, thank you, sir, for feedback on the subjects I stated. Word of mouth by a professional as yourself will be beneficial to the ones still getting addicted to narcotics, that of which are good for court and records on legal matters. Okay? Thank you for watching again, Shannon, for your comments. That's what we have for questions at the moment, Doc. This is a common issue, not very common issue. How often do you find cervical medullary syndrome associated with CCI? How close cousins are these? And as we perhaps wrap up, as we come to the half hour, we're out of questions. What else should people know about the topic?
Yeah, so cervical medullary syndrome, we find in about 1 in 4 patients who have CCI, so it's pretty common in CCI. Now, if we take everyone out there walking around with a headache, it's not going to be super common, but it is something that needs to be looked at and can be looked at by just looking at a routine cervical MRI. You do need to realize, though, just like the patient I spoke to last week, that a lot of doctors aren't looking up in this area when they order a cervical MRI. They're looking at C2-3 down, and we're talking about a problem that happens at C1, C2. So a lot of times, even though it might be sitting obviously on a cervical MRI, it's not really commented on by the reading radiologist. It's not really looked at by the surgeon unless you're seeing someone who focuses on this specific area. So that's something to just be aware of, that when cervical MRIs are generally ordered, people are looking below this area, not at this area.
Would you recommend that if they're concerned that follow up with a second report? Do they talk to their primary doctor and ask, did you look for cervical medullary syndrome? What should people do with that information, knowing that not many are actually looking for it?
Yeah, it's going to be hard for sure to confirm that the doctor really even knows what this is. So listen, if you've got CCI type symptoms, a great place to start might be something like some of the CCI Facebook groups or craniocervical instability Facebook groups, or other groups to look at might be the ME groups, the myalgic encephalitis groups, or the groups on cervical medullary syndrome, in order to get a better sense of if there's someone in your area who might understand upper cervical problems. And a lot of times that may not be the local neurosurgeon, frankly, because they don't really treat this area very often. It might be your local upper cervical NUCA or AO chiropractor, because they see these patients all day, every day.
Exactly. Justin follows up. He says, my MRI showed a thyroglossal duct cyst. I was told it's genetic. He's asking, is there any possible connection to CCI, or is it just a coincidence? He's looking to find out if there's a causal relationship or just coincidental.
Probably congenital, but listen, realize that all of these anterior muscles and structures can end up getting beat up in CCI patients, because these become secondary or used as secondary stabilizers of the head on the neck. Now, and an awful lot of those secondary stabilizers connect into the hyoid bone, which is approximately where many of these cysts are found. So it's possible that these structures getting beat up led to the cyst. Maybe there was a connection there congenitally that wasn't a big deal until the CCI started to beat up these structures. So there could be a connection between the two.
This is always the interesting, what I refer to as the Sherlock Holmes part of the story, which is you got to find the clues in order to put together the mystery in order to be able to solve, I guess you call it the crime or the incident. What would you recommend Justin do? If he has imaging, should he be reaching out to you, sending you imaging, getting perhaps on a telehealth appointment? And would you be able to sort of look at his imaging and help him perhaps in more detail?
Yeah, I think that's a good place to start. Obviously, he's probably seeing an ear, nose, and throat or ENT physician about this thyroglossal cyst. So obviously get that perspective as well to see if there's anything they can do and what needs to be commonly done. But at the same time, I'm happy to look at it from the perspective of, could CCI have caused this issue, or maybe taken a predisposition to this issue and made it worse?
Always cause and effect. Rarely do these things just spontaneously happen. Always cause and effect. We got one last question coming in. Last call for questions before we wrap up, just so you know. But Lassie Metler asks the question, have you heard of LifeWave patches?
I have. And I think I would be cautious. I actually reviewed this, oh God, a long time ago. I'm trying to think. Let me see if I even did a blog on it. I may have. Let's see here. I think I blogged a little bit on this. Nah, I didn't. Anyway, I looked into this for a patient a long time ago. I wasn't real impressed with LifeWave patches. This is a device that's been around forever. It got kind of rebranded as a regenerative medicine device. It's a multi-level marketing thing. And I was unimpressed with the entire concept, the science they presented, and the rest of it. So after checking into it about 4 or 5 years ago for a patient who asked me to take a look at it, I basically concluded it's not something that we would get involved with.
All righty. Thank you for your question, Lassie. If you've got final questions, now's your time. Otherwise, we'll start wrapping things up. Lassie, one of the things, I guess, for any of these types of questions is always to sort of recognize the difference between the symptom and the problem. And they're often not the same. Just as a alarm sound, a fire alarm sound, is not the same thing as the actual fire. It's the signal, it's the sign that something isn't okay. but oftentimes people confuse the alarm signal and shutting off the alarm signal with correcting the cause of the problem. And anytime you're wondering, should I be looking at this? Should I be looking at that? Should I be looking at the other thing? What you want to be asking yourself is this just simply temporarily relieving my symptom? Or is this in any way finding and correcting the cause of the symptom? Because those are two very, very different pathways. And unless you know the difference, you and millions of people are very faultily confused with turning off the alarm system and confusing that with correcting the cause of the problem or putting out the actual fire. If all you do is chase the symptom, you are leaving that underlying problem continue to get worse over time. Something to make sure that you understand, because that's how you get your power back, which is what this show is all about. We'll close up with this final question from Maria, who makes the comment, I found that a pill like lorazepam, it is calming, dissolves nearly all my symptoms. I heard from many others too. How can this match when I have CCI/CMS?
Yeah, lorazepam is a benzodiazepine, so that's a drug like Valium that tends to relax muscles. So realize that in some CCI patients, that's going to make the problem much, much worse because they need those tight muscles. In other CCI patients, a slight relaxation of the spasming muscles that are trying to hold everything together may actually be helpful, because some of their symptoms, for instance, could be due to irritated nerves that are from that muscle spasm. So that's not going to help all CCI patients, and it's addictive, so be careful there. But it may help the symptoms of some CCI patients.
All right, we got a last moment question from our friend Damian Golden, regular viewer, so let's get you in here. He says, good afternoon. Have you recommended joint distraction arthroplasty, and why? Do you any doctor recommendations for the surgery in Florida?
Joint distraction arthroplasty, I need to know for what. I'm assuming, since Damien has asked other questions about ankle, that we're talking about doing an arthroplasty of the ankle, which I'm assuming is the tibio-talar joint in the ankle, meaning an ankle joint replacement of the main ankle joint. Assuming that's the case, would I recommend that? Oh, that would really depend on knowing an awful lot specifically about that patient, what they've tried, etc. So too general for me to answer, but if Damien, if you want to get on a telemedicine consult, that might be a good place to start.
Perfect place to start, Damien. Again, we appreciate you being a regular viewer and always asking great questions, so thank you for that. That is our show for today. We really appreciate you watching. What I'll remind everybody is that if you're wondering whether your next procedure might be covered, you can go to the website regenxcoverage.com and find out if you're one of the up to 8 million people whose employers are provided, who are contracted with the RegenX network and provide their employees these types of covered benefits. That's our show for today. It was all about cervical medullary syndrome. As you know, we are here on Mondays at the Centeno Schultz Facebook page. On Fridays, we cruise over to the RegenX Facebook page. You're invited to watch us in both places. Please make sure you click the subscribe or notification button on each so that when we go live, you get a nice little notification. And of course, if you don't watch us live, you can always watch us on the replay. And our only ask is that you please take a moment to share this with other people that you know. Engage with us. If you've got comments, if you've got questions, ask them and leave them. But if you know people that are suffering, if you know people that are wondering, what should I do? Why am I suffering? Who can I talk to? The answer is check in and watch You've Got the Power with Dr. Chris Centeno. That is the place for you to get direct access to the world's foremost expert on these topics. You get to ask your questions live with the experts, and that's really what this program is all about. Dr. Centeno, any closing comments?
Yeah, just that, again, cervical medullary syndrome is real. It's an issue. It is associated with CCI, so it's important for us to understand that it's there, and that could change the way we approach that particular person's PICL procedure.
All righty. This is all about giving you more information so you know how to make the right decisions for you and your healthcare. We thank you for watching. We really appreciate it on behalf of Dr. Chris Centeno. I'm Dr. Jason Deitch. Thank you for watching. We'll see you on Friday. Until then, stay well and be kind.